Hello guys, welcome to the classic ophthalmology. In this video today we are going to study an overview of oculomotor nerve, and in the next video we will go for the clinical presentation. So in this video we are going to study about the anatomy, physiology and its clinical aspect. Now different type of questions can be asked in the oculomotor nerve, like discusses the origin, course and muscle supplied by the oculomotor nerve, the anatomy of third nerve nucleus and various manifestations of the in its course. Okay, so in this video today we are have an overview of embryology, nucleus of third cranial nerve, its course, its blood supply and the muscles it supplied and the clinical aspect. The third cranial nerve is purely motor in its function. We know this, and it develops from the medial row of the neuroblast of the neural tube. Remember that, medial row of neuroblast of the neural tube. Now the nucleus of the third nerve or oculomotor nerve is situated or is located in the midbrain. Remember this, it is located in the midbrain and it surrounds the cerebral aqueduct, and it lies at the level of superior colliculus. Okay, so these three are important. The nucleus is located in the midbrain, it surrounds the cerebral aqueduct and it lies at the level of superior colliculus. Now this is our superior colliculus, this is our cerebral aqueduct. Okay, this is our cerebral aqueduct. Now the nucleus of the third nerve has two components. The one is main or principal nucleus and the other one is a accessory nucleus, or it is also called as a Edinger-Westphal nucleus. You can see in this picture. Now this is our main nucleus or principal nucleus and this is our accessory nucleus or Edinger-Westphal nucleus. Edinger-Westphal nucleus, which is associated with the parasympathetic activity of the third nerve. Okay, so this is the nucleus of the third cranial nerve. Now the principal nucleus or principal component of the oculomotor nucleus has 5 subnuclei which supplies the 5 extraocular muscles: the dorsolateral, intermediate, ventromedian, paramedian and caudal. Okay, the dorsolateral supplies ipsilateral inferior oblique muscle, intermediate part supplies ipsilateral inferior rectus muscle, ventromedian supplies ipsilateral medial rectus muscle, paramedian supplies contralateral superior rectus. Remember this, contralateral superior rectus, and the caudal central supplies bilateral LPS muscle, okay, levator palpebrae superioris, and the accessory muscle, as we know that it is associated with the parasympathetic activity. Now the third cranial nerve, as it passes from brain to the eye, has 4 parts. The first one is a fascicular part, second one is a basilar part, third one is a intracavernous part, and fourth one is a intraorbital part. Okay, so these are the nerve is divided into these 4 parts: fascicular, basilar, intracavernous and intraorbital part. Okay, now this is our midbrain, and this is our midbrain, and this is our nucleus. Okay, this is our nucleus. The third cranial nerve or oculomotor nerve arises from the nucleus and emerges from the midbrain. Okay, emerges from the midbrain, and this part from the origin to the emergence of the midbrain is called as a fascicular part. Okay, the part between origin and its emergence from the midbrain is called as a fascicular part, and this nerve passes to the cavernous sinus, and this part between midbrain and the cavernous sinus is called as a basilar part. Now from the cavernous sinus, from the anterior part of the cavernous sinus, the nerve passes to orbit, and this part orbit, okay, now this part and orbit supplies the extraocular muscle. The part between cavernous sinus and the orbit is the intraorbital part. Okay, it is intraorbital part. So the fascicular part, basilar part, intracavernous part, and intraorbital part. Now in the orbit, the nerve divides into superior and inferior division. The superior division will supply LPS muscle and superior rectus, whereas the inferior, which is a larger branch, supplies the medial rectus, inferior rectus, and inferior oblique muscle. Okay, this is our pretectal nucleus. This is section at the level of superior colliculus, and this pretectal nucleus is associated with the light reflex. Okay, now this is pretectal nucleus. This is our red nucleus. The nerve passes through the red nucleus. This is fourth nerve, this is sixth nerve, and this is our cavernous sinus. Now when the nerve emerges, it passes between superior cerebellar artery and posterior cerebral artery. Okay, the nerve passes between superior cerebellar artery and posterior cerebral artery. This is our basilar artery. Okay, so this is our basilar artery. Okay, this is our basilar artery. Now this is our cavernous sinus. Okay, this is our cavernous sinus. The third nerve from as a basilar enters the cavernous sinus through the roof. Okay, through the roof. Now in this picture we can see that this is our pituitary gland. Okay, this is our pituitary gland. Superiorly we can see that this is our oculomotor nerve. This is our third nerve. Just inferior to it is the fourth nerve. Okay, fourth nerve. Below this there is first division of trigeminal and second division of, this is the second division of fifth cranial nerve. And this is the third division of fifth cranial nerve. Now inside this cavernous sinus we can see this nerve is the sixth cranial nerve, abducens cranial nerve, and medial to it lies the internal carotid artery. Okay, so this is the internal carotid artery. Now this is superior orbital fissure. Okay, so this is the orbit, and a nerve enters through the superior orbital fissure into orbit. This is superior branch, this is inferior branch. This is in between the two, there lies a nasociliary nerve. Okay, nasociliary nerve. This is superior orbital fissure. The nerve enters through the superior orbital fissure into the orbit, and this is tendinous ring, this is optic canal, and in the optic canal we can see that optic nerve and ophthalmic artery. Okay, optic nerve and ophthalmic artery. Now the superior and inferior inferior to this tendinous ring there lies inferior branch of ophthalmic vein. Okay, this is superior ophthalmic vein, and there lies three nerves in the superior part outside the tendinous ring. Okay, lacrimal nerve, frontal nerve, and trochlear nerve. LFT. Okay, and just below these superior and inferior branches of oculomotor nerve, there lies abducens nerve. That is sixth cranial nerve. So this is very important. Okay, fourth nerve lies outside. Okay. Now orbital apex syndrome. Involvement of third nerve, fourth nerve, sixth nerve, and the optic nerve. Okay, it is orbital apex syndrome because optic nerve lies in the cavernous sinus thrombosis. There is no involvement of second cranial nerve. Optic nerve is not involved in the cavernous sinus thrombosis. Okay, now what are the clinical features of third nerve palsy? Now the first and very important, ptosis. Okay, so there is a paralysis of LPS muscle, it leads into ptosis. Now due to the paralysis of medial rectus, inferior rectus, superior rectus, and inferior rectus and inferior oblique, there is outward deviation, outward and downward classical deviation of the eyeball, and it is due to the unopposed action of lateral rectus and superior oblique, because the lateral rectus is supplied by sixth cranial nerve and superior oblique is supplied by fourth cranial nerve. So there is a unopposed action of lateral rectus and superior oblique. So there is a deviation in the outward and downward direction. There is a restriction of adduction due to the paralysis of medial rectus. There is a restriction of depression due to the involvement of inferior rectus. There is a restriction to the elevation due to the involvement of superior rectus, and the extorsion is also restricted due to the involvement of inferior rectus and inferior oblique. Due to the alignment of the eyeball is changed, there is a diplopia, and due to the involvement of sphincter pupillae, which is supplied by the Edinger-Westphal nucleus, the pupils are dilated. Okay, dilated, and they are fixed, and there is a sometimes due to the loss of accommodation there may be the difficulty in the near vision, so these are the classical symptoms of third paralysis. Okay, third nerve paralysis: ptosis, outward and downward deviation of the eyeball, diplopia, and sometimes fixed, mid dilated, not reacting pupil due to involvement of sphincter pupillae. Now let's suppose that in this case the right oculomotor nerve is involved. This is right eyeball, this is left eyeball, this is the right eye, this is left eye, and in the right eye, suppose this is right eye, involvement of third nerve, the left eye appears to be normal. Okay, but the right eye is directed outward and it is directed downward. Okay, so the outward and downward direction eyeball is classical of third nerve palsy. What are the different lesions that can be occur due to the course? Now we know that this is the nucleus, and the part between the origin and its emergence from the midbrain is called as a fascicular part. Okay, that is fascicular part. Nucleus to midbrain emergence is the fascicular part. Okay, is the fascicular part. Okay, and there lies the red nucleus and cerebral peduncle, it crosses. Okay, now the first one is a Benedict syndrome. Now this is the red nucleus, and due to the involvement or due to the lesions in the red nucleus associated with third nerve palsy, there occurs contralateral tremors due to involvement of red nucleus. It is called as a Benedict syndrome. Okay, so the ipsilateral third nerve palsy with contralateral tremor is suggestive of involvement of red nucleus. Now the second one is a north nagal syndrome. Okay, now this is the midbrain. Okay, this is the midbrain, and involvement into the area of tectum of the midbrain is associated with the cerebral ataxia. Okay, so the bilateral or unilateral third nerve palsy associated with cerebral ataxia suggestive of lesion into the tectum and is suggestive of north nagal syndrome. North nagal syndrome. Now the third one is a Weber syndrome. Now the nerve passes through the cerebral peduncle, and any lesion in the area of cerebral peduncle is associated with contralateral hemiplegia. So, ipsilateral third nerve palsy associated with contralateral hemiplegia is suggestive of lesion in the region of cerebral peduncle and is called as a Weber syndrome. Okay, so any lesion with their symptoms, we can localize the area of lesion. Now the fourth one is a Claudy syndrome, and it is nothing but Claudy syndrome is nothing but it is a combination, the symptoms combination of north nagal syndrome and Benedict syndrome. So it consists of combined features of north nagal syndrome and Benedict syndrome. Now, lesions in the basilar area of the third nerve, these are usually associated with the isolated third nerve palsy. Okay, isolated third nerve palsy. While lesions in the intraorbital region are associated with the isolated muscle palsy. Okay, isolated muscle palsy. Now this is the orbit, this is the oculomotor nerve, and in this the green are nothing but the pupillomotor fibers. Okay, and these are located superficially. Okay, out just superficial part, and so these are located superficially. Now this is the blood arterial supply of interior of the oculomotor nerve. Okay, remember these are vessels which are supplies, these are micro vessels, this supplies the interior of the oculomotor nerve. Okay, and these are called as a so these are supplies interior of the oculomotor nerve. Okay, and these are called as a vasa nervorum. Okay, vasa nervorum. These are micro vessels. Okay, and supplies interior of the oculomotor nerve. So these are damaged in the microangiopathy, such as diabetes or hypertension. So diabetes or hypertension, and hence the pupillomotor fibers are usually spared in this. Okay, because the pupillomotor fibers are not supplied by these vasa nervorum. So microangiopathy does not involve the pupillomotor fibers. Hence the diseases like hypertension and diabetes mellitus, these usually spare the pupillomotor fibers, and the third nerve palsy from these diseases like DM and hypertension are usually pupil sparing. Now the pupillomotor fibers get their blood supply from the these are superficial fibers, and they get their blood supply from the pial vessels. Okay, pial vessels. Now any tumor or any aneurysm like surgical lesions can compress or occlude these vessels, tumor or any aneurysm, and may compress these pupillomotor fibers. Okay, you can see this in the image. Any tumor or aneurysm can compress these pupillomotor fibers, which lead to the third nerve palsy, which is pupillary involving. Okay, because the pupillomotor fibers are involved in this or compressed. Okay, so these lead to pupil involving third nerve palsy. Diabetes are pupil sparing, and the tumor or aneurysm are pupil involved third nerve palsy. Okay, so this is important. Now the medical causes. Okay, as per discussed, the medical causes like hypertension, diabetes, or infarction. Okay, these lead to pupil sparing third nerve palsy, whereas the surgical lesions, okay, the surgical lesions like tumor or aneurysm, they compress the pupillomotor fibers, and hence they are pupillary involved third nerve palsy. Okay, pupillary involved third nerve palsy. Okay, so these are two important. Now the causes of third nerve palsy, there can be multiple causes. Now the most common are trauma, okay, traumatic, like hematoma, hemorrhage. The second ones are like aneurysm, okay, aneurysm, diabetes mellitus, hypertension, microangiopathies. Okay, and last but very important, yeah, most of the cases are maybe idiopathic. Okay, the cause cannot be identified in certain cases. Tuberculosis, syphilis, inflammatory diseases, or infiltrative diseases may also cause the third nerve palsy. Okay, now the investigations. Now very important that the disease must rule out the diabetes, blood sugar level, hypertension, blood. These two are very important. Now apart from this, the other like magnetic resonance angiography and CT angiography, these are very important in the certain cases, importantly in the pupillary involvement. Lumbar puncture can be done, but important that the in wherever there is a pupil involving third nerve palsy, it is suggestive of any surgical lesion, and these two, MRA and CT angiography, these are very important and should be done as early as possible. Okay, as early as possible, especially in the age group of less than 50, because tumors and the aneurysms are uncommon, and pupillary involvement of less than 50 years are suggestive of emergency investigation. Now treatment, usually the third nerve palsies are self-limiting or they require conservative treatment, and they usually regress by 6 to 12 months. Now any complications of the third nerve palsy like muscle involvement or ptosis, they should be considered surgically after 6 months to 12 months only. Okay, so these are few important points. The same case presentation of this case we will be done in a part 2 of this video. Okay.